Is your doctor treating your symptoms or your whole self and getting to the root cause? Today, we uncover what integrative medicine is, why it matters, and how it transformed your care. Welcome to WellWaveNOW, your portal for actionable wellness insights. We, Breck Rice, Dr. Bob Levine, and me, Tim Daniels, are your wellness catalysts, committed to elevating your health, enhancing your functionality, optimizing your performance at every life stage. WellWaveNOW, where timeless wisdom lights your wellness path. Today, it's my pleasure to bring to you our guest, Dr. Bruce Feldman. He's a highly respected integrative care MD who has successfully been serving patients for decades. With a background in internal medicine, Dr. Feldman bridges the gap between traditional diagnostics, complementary modalities, and holistic lifestyle-based care. His patient-first approach combines science, compassion, real-world results, and today is here to help us understand what integrative medicine and integrative care are really all about.
Hey, thanks for joining us today, Dr. Feldman. It's great to have you on.
Yeah, it's fun to be here. Thanks for having me.
Yeah, so let's jump into the definition first. What is integrative medicine?
So, it's this is one of the funny things, right? So, integrative medicine is a term that was generated probably 25 years ago or thereabouts, which was the first effort from a conventional medicine standpoint to create a box that encompassed all the stuff that wasn't regular conventional medicine, right? So integrative medicine includes things like energy medicine, maybe Reiki, acupuncture, chiropractic, herbal medicines, aromatherapy. All of these things fall into the integrative medicine space. So there were integrative medicine programs where you could go and you could get this smattering of different stuff, right? So there's value there, but it was really put in the corner. We know it exists, put it over there, and people can go there if they want to.
Yeah.
So in that case, I almost equate that almost to alternative care. Are you saying in the pure definition that alternative care is the same as the buckets that people put integrative care into?
Yes, pretty much.
Okay.
Pretty much.
Well, also integrative medicine in a way implies that you can get conventional medical care along with the other
Correct.
Alternative care. And so we had an alternative. We had a Center for Integrative Medicine at Henry Ford Health System when I was there that I co-directed, and we had all the other modalities, the alternative medicine approaches, and we also had an MD there who could see people. So hence we called it the Center for Integrative Medicine.
Yeah, what it basically is an attempt for most of a lot of facilities, hospitals and the like that had primary care delivery systems found that the market needed to be addressed. So this way they put it on the couch of the internal medicine or the primary care practice in some fashion. And they put them all in the same room. So it legitimizes the fact that they can bill for it. But oftentimes a lot of that stuff was not covered by insurance. And it was a play to the market, basically.
Yeah. So just to be clear, though, your practice is integrative care. How do you differentiate integrative care versus integrative medicine?
Right. So the reason I'm called FeldMed is because I don't fit in the box. Okay. So the box is my creation, right? Feldman made medicine into FeldMed. So I do a little of everything. And I joke about, I do everything from stem cells to witchcraft, but I don't do stem cells or witchcraft. There's a lot of stuff, and I do things in a lot of different ways, trying to find the best option for the individual. And a lot of times that falls outside of the conventional medical approach, or it is adjacent to the medical approach, right? But it's an angle that is different and won't necessarily be seen by the conventional folks as, yeah, I don't know, I think he's making that up. Well, no, I'm not.
So you have a background in internal medicine. You were board certified in internal medicine.
I was board certified for 30 plus years,
Yeah.
and decided that on the fourth go round, I wasn't going to bother. Right.
Yeah. So you've been you were board certified longer than I've been alive, Dr. Bruce, you know. How about that?
That's pretty funny.
At one point.
In your dreams,
Yeah.
Tim.
Yeah, that's
Yeah, I
pretty
figured-
funny.
Well, at least some of his cells haven't been around for
There
30
you go,
years.
yeah.
There you go. That's
See,
fair.
with all my integrative care that I apply, you know, I've aged backwards here.
Oh, there you go.
age.
Right. Your
Slowed down the
biological
points.
age, isn't that
There
right?
you
I
go.
got you.
So it's
Well, tell me when you
biological
get back
age.
to diapers, will you?
He's just trying to be Benjamin Button, you know.
Yeah.
There you go. But so with that background and that experience and having been there for over 30 years, what drew you to the integrative care model? And I might call this integrative medicine as we go along, because what you described integrative care is what I truly think integrative medicine
Should be.
should be.
Right.
And
Well,
when I look at
I mean, I can go with that. I mean, I'm not going to be offended by that. So, you know, I was in primary care practice in Massachusetts in the early 90s, and it was managed care heaven, and everybody had managed care, and HMOs were a bad word, and people were taking my money, and I wanted to know why. So I became a managed care expert, and I became a liaison to many different health plans, and I became the population management guy, and I knew how to run programs, develop programs, and pay doctors and do all that kind of stuff. And by the way, for people who don't know, HMO stands for Health Maintenance Organization, and the idea was to keep people healthy. Now, people in Florida and Texas had their own ways of manipulating the system, and the marketing of the HMOs was terrible. So they got a black eye, and it's never recovered. Okay. But the premise was good. Having said that, when you manage population, you're managing the center, right? So if I can take care of 75% of the population for not very much money, then everybody benefits. Well, not everybody benefits, because there are people out here on the edges that, you know, they're not getting taken care of. My approach now is basically, if you think about it, everybody has enough variation in which something that they have is not in that middle ground. If that one thing that's not in the middle ground happens to lie outside of the average, then the system is not designed to take care of that individual. So if that becomes the problem, they're kind of going to get screwed. And that has become my sort of point of contention. And when I was medical director and running a program for 100,000 people, I came to the realization that what really floats my boat is taking care of the people who are not being taken care of by the system. So henceforth, I couldn't stay in the system. I needed to get outside the system, and I started taking care of individuals, because those are the people who are not getting taken care of.
Good. All right. Beautiful. And so now, when another way people have looked at saying I need to take care of the individuals, they've looked at and said you got to be functional medicine. So, and I think what's important for our audience is to understand these differences, so they know what to look for and what not to look for. So if you look at integrative, functional, conventional, what do you see as what are the similarities, especially between the integrative and functional, and what are the differences, and are they important, Dr. Bruce?
So they are clearly important. A little sort of, I mean, I guess history is important here. Conventional medicine is really has become, in a lot of ways, functionally about taking medication, right? So originally, medicine was not that, but as pharmaceuticals became more readily available, it was much easier to treat the symptoms, right? Somebody comes in with a complaint, let me take care of that complaint. It didn't used to be that way, but now, life has gotten easier. It's easier to solve the problem, but the problem is not really the problem. The symptom is the problem in conventional medical stuff. And, I like to talk about conventional medicine as being an exercise in nomenclature. It's put a name on this collection of stuff, right? You get put in a box, and then the box is treated, right? The box being treated is you're treating the outcome of the problem, not the problem itself, right? So I have back pain, I'm going to get treated for the pain, right? Functional medicine at least attempts to figure out the cause of the problem and treat that. which makes great sense. Okay. What I find in a lot of functional medicine practitioners, first off, there's a huge focus on the gut as the primary place where everything starts. And there's good reason to believe that's true in a lot of cases. However, it is not true in all of the cases. Now, if you strictly follow the rubric of functional medicine and you do what is described, then you'll probably figure out the people who aren't GI primary, right, and get to where they're supposed to be. And there's lots of different, there's like 7 different pillars in functional medicine. But what I find is a lot of folks in functional medicine merely substitute supplements instead of pharmaceuticals.
Mm-hmm.
So as a consequence, if you go to a conventional doctor, he's going to give you 3 to 7 medicines, we'll say. The functional guy is going to send you home with a dozen, right? And you're taking lots of stuff. And, you know, is it working? Isn't it working? Well, the problem is, of course, is natural stuff takes longer to work. So you're on this stuff for a long time and you haven't figured it out. And, you know, is there good communication? There should be, but is there? It depends. You know, you have to go to a good guy, right?
That's true. Yeah, it's true.
And then the integrative medicine piece is the guys who are doing other stuff. So a really good acupuncturist is doing traditional Chinese medicine, not just acupuncture, right? Those guys are hard to find. And those guys are probably really good. Ayurvedic medicine, same kind of thing. You can get guys who know what they're doing, who sort of treat a broad swath of circumstance, but you got to find those people. And what I find in most cases, practitioners are very dogmatic, right? They are the carpenter where they have a hammer and everything looks like a nail. Okay. And I don't follow that, right? Yes, there are certain caveats from which we start, but as soon as something doesn't add up, then you got to go, wait a second. I don't think this is going to work. Let's think about this differently, right? And changing your perspective according to what's in front of you is really critical because permutations are vast. I do a lot of genetic work. Why? Because lots of different combinations can end up in the same thing, but you don't know what those combinations are.
Mm-hmm.
Okay. And you're going to guess, oh, well, I think it's this. Well, you know what? One's high, one's low. Well, you know what? The other one's high and the other one's low is going to end up in the same thing.
What's an example?
You know what to do?
What's an example of that? That would be really illustrative of what you're talking about.
So the one that comes immediately to mind is COMT and MAOA. Okay, so you got monoamine oxidase and CO methyltransferase, 2 enzymes that are responsible for neurotransmitter metabolism, right? So if one is high and one is low, then it's going to sort of mostly balance out. Now, the thing is that if one is high and one is low, the one that's high means it's going to metabolize quicker. Some of those are liver-centric besides neurotransmitter-centric. So you're going to have some side effect difference. If you have the other way around, then one's going to be slower. And, you know, one day you'll see somebody, they'll have a very fast sort of mood swings, let's say, right? So if they're both fast, you're going to go run through neurotransmitters very fast. You're going to be jumping up and down. You're going to be high, low, high, low. And then the opposite is if they're both slow, then you get in a mood and you're stuck in the mood. Okay. Well, again, if one is high and one is low, it makes a difference for the other stuff, right? And it's hard to differentiate those things. If you know one is high and one is low, then you can tailor what you give people or what you tell them to do. Do a sauna. Don't do high intensity training. I mean, you know, there's a lot of different nuances, and the nuances is where the money's made, so to speak.
Right. So, Dr. Bruce, you know, integrative medicine, you know, you're pointing out how complementary it is to conventional, but there are some challenges, right, to most conventional
a lot of challenges.
Models. So how do we get over those challenges?
So one of the things, you know, I mean, part of the reason I got out of the system, so to speak, is because I don't think I can change it personally, right? I don't have the skill set to move mountains, as it were. I'm just moving molehills, right? I'm trying to make it good for the individual. What you see, for example, reimbursement strategies. I mean, that's why I focused when I was in managed care stuff, trying to figure out how to incent physicians so that they're doing the right thing. Well, they do all these quality measures now, and it's shown that the average primary care doctor to successfully navigate all of the quality measures in a reasonably busy practice would only require 25 hours a day of committed time to that activity. Well, that's hard to do. So, it's not working. If you go to a doctor, people know they get FaceTime for however many minutes, it's single digits at this point. Some years back, the average primary care doc was seeing somebody for like 12 minutes, but the average primary care patient was coming in with 5.7 complaints. Well, how do you address all of that in 12 minutes? You can't. So as a consequence, the primary care guy focuses on the first problem. And in that study, the doctor actually did spend the majority of the time on the primary problem, which meant he spent all 6.5 minutes on that problem. And then what do you have? You don't have time to think through and integrate and review all the studies and everything else. So you send them to the specialist. So now the specialist looks at that individual problem. Well, that individual problem is tied to a whole bunch of other things, right? So just think about the gut-brain connection, right? If I send you to the gastroenterologist, he's not thinking about your mood.
Yeah.
So I fix, you're not constipated anymore, you win, right? Well, maybe it's not quite that simple.
Yeah, that's the problem. I mean, there's so many possibilities, and the conventional care system's not equipped to, handle all these wide.
It's not structured. Again, medical care in America was designed around acute problems, right? But the vast majority of healthcare today is lifestyle-related chronic disease.
Right.
Yep.
Right.
Yep.
Well, that requires a conversation, and one of the things that I've been talking about recently, people ask, well, what's AI going to do to healthcare and the like? We're going to replace doctors. Well, most of what I do today is aggregate data, organize it in a structure where I can now make decisions based on that organization and then communicate that to the patient. Well, the first 90% of that is all going to be done by AI. But the most important part is the last part. What I like to say is it's not what I tell you that counts. It's what you hear, right? So the physician now becomes really the only mouthpiece that can respond to that patient and get them to do or think or act the way they need to for their own benefit.
But isn't that still tough? Because a lot of doctors friends with say, I can't get people in general to do what I ask them to do. If they would just do what I ask them to do, they could get better and have a higher quality of life. They just won't do it.
No, but that's what differentiates the guys who are, good from the guys who are just, average.
Ordinary, yeah.
But I mean, the people who sit in my chair, so to speak, I mean, they're there because, a lot of them are there because they're just told what to do. They're not part of the decision-making process, so they're not engaged. They're handed a prescription for 5 different things and go to physical therapy and get this test and whatever. And they're like, I don't want to do that.
Right.
And then they're done and they don't do anything. Right.
Right.
And they know that's the wrong thing to do, but that guy hasn't made any connection that inspires them to change their path. It's fundamental.
Do you see patients longer? I'm sorry. Did you see patients longer in your practice than you did when you were back in conventional care?
Of course.
That's important for people to know.
No, my average first visit is like 2.5 hours and my follow-ups are an hour.
How should people get ready to be engaged in their process as they interact with their providers? And how do you help yours get ready, Dr. Bruce?
I almost find that question offensive. Okay.
Why?
Because you're the patient. It is not your job to necessarily get ready to go see the doctor.
How about questions? How about questions?
Let them go.
You don't have to prepare your questions unless you can't think that fast, right? Right. The doctor should be engaging with you to discuss that which you see as important. And if you're, I had this. So people talk about, did he do a physical, right? Well, you know what? the physical is only confirmatory in 95% of your visits, right? So that doesn't mean you shouldn't do a physical, but don't expect the physical to be the answer to your problem. Where's the answer? The answer is in your history. Studies show that in a busy primary care practice over a 5-year period, that's about 20,000 visits, the practitioner will identify problems that the patient has that the patient didn't know they had 3 times. So if they know they have it, then you need to figure out that they know they have it, which means you have to take a history, which means you have to ask them a bunch of questions and you've got to steer them down the path to show that there's something not quite right. And then when you go examining that, you know what? There's the problem.
Yeah. Well, so let me give you, and you'll have to explain to me a little bit more why you almost took that as why offensive. But so let me give you a little bit on what I mean by preparation. And I'll use my own self for a couple of examples. Last year, there was a thought after somebody did a little biopsy on me, that I had this rare blood disease called Rosai-Dorfman. And if I hadn't looked up that Rosai-Dorfman and studied it, we'd have ended up going to Australia as opposed to going someplace
down the street.
Because I said, look, okay, here's some causes of this. Well, let me tell you to your point, history, let me tell you what I'm experiencing and what that thing is saying there. I don't think this is the case. Have you looked at this? I said, look, you found I had a UTI. Well, that UTI was caused by Klebsiella oxytocin. Well, don't you know that Klebsiella oxytocin sometimes it can trigger Rosai-Dorfman, but it can also cause confusing things. So we went through that. And this was at a very, very, they sent me to the specialist. And they sent me to, and to your point, but the specialists also tried to get together. I went to see 3 or 4 specialists, but they formed a little committee and they all met in this place and I was a case study. Okay, so finally I'm with the hematologist and said, we don't find this, we don't find out, we don't see that there. I said, I don't think I have it. And he says, well, we could light, and it was a key. And again, we said, we could light you up with a PET scan. And that key, when he said, light me up, that was my key to ask a question. And that's why you got to tune in and be prepared to ask a question. But if I also hadn't looked up this Rosai-Dorfman, I wouldn't have known how to ask that question. Because I said, look, if I have this thing, which you can't find anything aside from this one item here, and which I think is indicative of something else, and here's why I think it's indicative of something else. But if you go in here and we do a PET scan, at this point, if you find it, what will we do? What he said, exactly. You're not symptomatic. You don't show anything. We're not going to do anything. So we shouldn't. At one point, he should not. I guess he would have been remiss if he hadn't offered the PET scan to me. But he didn't want me to take it, and he couldn't say that. So I had to prepare. If I'd been unprepared, I'd have had that PET scan. And
but Tim, aren't you 1 in 100? Like, how many people are going to prepare?
I don't know, but that's why. I say.
So I will tell you that I'm going to tell you that the majority of my patients are much more like Tim than not.
Yeah,
that's because they're coming to see you because they know better.
Yeah.
Right.
Yeah.
Right. So I am not bothered by highly educated consumers, as it were. Mm-hmm. The only exception I would take there, Tim, is that every test that you order should be couched in the what am I going to do different? Yeah. So my conversation would have been different than with your hematologist. I would have said very plainly, look, the next step in this process would be to get a PET scan. Mm-hmm. The reality of getting the PET scan is, even if you have it, we're not doing anything about it. Yeah. So what I suggest is let's revisit this in, 6 months, a year, whatever it is, and we'll think about it again then if there's any symptoms, if there's any stuff. And then, there are certain advantages to going to a specialist, again, so long as they're good ones. Mm-hmm. So the good guys, primary care, they're not supposed to know the subtleties of all of that. They're just supposed to be able to recognize, oh, shit, here's the problem. Let's go. Let me send it to somebody who can figure it out, right?
Right.
And then you send it to the guy to figure it out. And he's like, yeah, you don't have to worry about that. Well, what is he worried about? Well, don't worry about it. It's nothing. It's, again, on a routine blood analysis, these days, you're talking about well over 50 parameters being measured.
Right.
Well, with a P of 0.05
Meaning
means
the
that five.
meaning I just want to say it's a probability estimate that just explain the PO5 so our
Yeah, I was
listeners.
gonna do
Oh,
that. Yeah.
sorry.
So,
Go ahead.
so you have a 50% chance that 5 out of 100 are going to be abnormal purely on the basis of chance. So if you do 50 of them, you got a pretty good chance something's going to come back wacky, and then you're going to have to go figure it out, right? This is the argument against a full body PET scan, MRI scan, CT scan. Why? Number one, everybody's got something funny.
Yeah.
Everybody.
Yeah,
Okay.
for
So
sure.
the chances that you're going to have a perfectly normal 100% test is almost zero, which
Right.
means now you find something. What are you going to do about it? Well, the doctor is now under an obligation to follow up that test because you're going to sue them if there's something there that you didn't do anything about. So now you're obligated to the next test. And then God only knows how many of those tests are required to get the definitive answer that you don't have something that never bothered you in the first place.
Or you have it, but it's not bothersome, and you have to wait to see if it
I mean,
bothers
there's a
you.
whole, yeah, I mean,
Yeah.
it's a big
Yeah.
cascade of stuff, right? So
Yeah.
it becomes very tricky. You know, the argument, some people will argue, well, if I don't want to do a genetic test because it's going to show me things that are, problematic, and then I'm stuck with that. Yes and no. The reality, of course, of genetics is only about 35% of what's in your genes turns out to be true ultimately, because it's all about the epigenetics over which you have tremendous control. So
let's go with that. And I nod on my head at the epigenetics, and Bruce is leaning for, but Dr. Bob could explain epigenetics, and Breck can, but I can't, Dr. Bruce. So you gotta tell people what epigenetics is all about.
all right, well, I'll give you my quick and dirty. So genetics are your DNA, right? So that's what gets passed on generation to generation. It is largely immutable. It doesn't change. When I say largely, it's because there are mutations, and bad things usually accrue to mutations, but that's a relatively rare phenomenon, not what we're talking about. Again, 35% of what you turn out to be is from your genes. Some are highly penetrated, highly dominant. They occur in, everybody who's got that gene. That's pretty unusual. Most genes are multifactorial. Most genes require a whole bunch of things to line up in the same direction at the same time for them to manifest. There are, in most of our genetics, however, our DNA is largely composed of repeat sequences of signals and switches. There's a lot of stuff in your DNA that doesn't, quote unquote, do anything. I'll argue, of course, that it used to, and then it got obsolete, or it's been permanently turned off or whatever. But anyway, there's lots of switches. And it's really, I mean, like the Pinot Noir grape has 10 times as many genes as the human body. Well, what the hell is that? That's crazy. Well, it turns out that there's lots of switches and combination switches that makes for more permutations in us than in the grape. Although I'm very fond of some of that grape. Now, the switches are either turning on or turning off, and everything you do or don't do, everything you say or don't say, every person you talk to or don't talk to, or come in contact with, or where you live, or where you sit in the sun, or the lighting you choose, everything affects some switch or other. So every second of every day, you have an opportunity to change your epigenetics. Now, you may not know whether or not your choices are good or not, but some are really obvious. Like smoking that cigarette, that's obviously the wrong choice, right? That's going to turn your epigenetic switches in the wrong direction most of the time, and that's going to end up being bad for you, right? Having a conversation or being forced to have a conversation with somebody you don't want to have a conversation with, or that really you don't like, right, is a negative influence, and it will negatively impact your genes. So I like to say, hey, that guy is killing me. Yes, he is, right?
No, you're allowing him to kill you.
There are epigenetic changes that are occurring. But one can also, and if we want to go further afield, we start talking about energetics and energy medicine and things like that, and spirit and other kinds of things. And to negate that is a complete failure as far as I'm concerned.
Yeah.
Because what's the difference between a live body and a dead body?
The live body's got energy.
The life force, right?
Yeah,
The
right.
biochemistry is all the same. It's just somebody pulled the plug.
Yeah.
Well, what is
I heard
the
somebody,
plug?
yep, and I heard somebody, and I'm stealing this one. Soon it'll be mine, articulate. But for a while, I'll give credit to somebody else for saying this. And they looked at it and said, just to your point, it's a conventional medicine, all based upon, as we practice it today, as you said, cells responding to medication. Well, it's becoming more and more known that cells respond better to energy than they do to medications to be able to check if I can change things.
Well, so, we had this conversation before. As far as I'm concerned, pharmaceuticals are by design selective toxins, and they are designed to impact a single pathway, right? And it's our hubris to believe that nature has created a single pathway. No, there is redundance everywhere. So you're blocking the single pathway that you think is the most important. Well, newsflash, there are other pathways that may be equally important down the road that you're screwing up by taking that drug. Now,
also the drug.
There are certain cases where that becomes really important because that pathway is very critical in your particular situation. But if there are alternatives, they should probably be explored.
Those drugs are attacking all kinds of pathways. I don't believe that we think that we invent a drug that addresses a single pathway, but I don't believe that for a minute. These drugs are getting in there. They're hitting all kinds of targets. That's what I think anyway.
The only drugs that I can even give a little bit of nod to. So the first drug in the class was acyclovir, which was designed against the herpes virus, right? And there's an enzyme that exists that doesn't exist anywhere else. It only lives sort of in the viral genome or whatever. So you screw that up, and then theoretically, you don't do anything to the human. Having said that, I know plenty of people who have taken that drug who have had side effects. So
yeah, sure.
It's clearly doing something, right? But that's about as clean as it gets. So
when I give lectures to whoever it is, whether it's physicians or anybody else, I always say there's never been a drug invented that addresses the underlying source of an illness. They're just all masking symptoms, and that's it.
Now for you too on that one. There's a class. I'll throw out a question for you then. What about antibiotics? What do you think about antibiotics?
What about them?
Well, you said there's not a drug that doesn't address the root cause.
Yeah, right. Why is there an explosion of bacteria when there wasn't before? They were existing in a certain balance, and then all of a sudden they're out of balance, and you need the antibiotic to help restore proper balance. You're just restoring proper balance, but it's not addressing the source of why did
you're not actually, and in fact, you're not actually restoring proper balance. You're destroying whatever's there to a large degree, and then, as I say, what our function as practitioners, in my view, has always been to attempt to remove the barriers that society and community and environment has created to allow our bodies to be back to their natural state, which is one of health. That's why people get better, because bodies want to be better. And we get in the way over and over and over again.
Yeah. So let's stay on this point with antibiotics for a second, though.
Uh-oh, Tim's on a roll.
So in the Dr. Bob approach, we'll bring you in here since you and Dr. Bruce are teaming up here. We'll let you team up here because it takes two of you to argue with me.
That's true. Well, I don't know. I really
let me finish the question, Bob.
Yeah, we should do that for sure.
Which is, okay, so patient Z comes in and they've got this Klebsiella oxytocca bacteria. Are you not going to prescribe them antibiotics? Are you going to give them energy medicine to get away with it? Are you not going to use that tool? And
so, by the way, okay, so that's good. So let me start with this. So we have a technology called bioresonance, Okay, bioresonance measures frequencies of organ systems and other entities. So we can identify the frequency of that bacteria. Similarly, we can identify the frequency of the antibiotic that you would suggest for that bacteria. I can then apply an energy field in that frequency and actually kill that bacteria with no antibiotic present. Now, that's a very specific therapy that has virtually no side effects as a consequence because it is so tailored and so specific.
Yeah,
what do you think of that?
Yeah, the three of us are very much into pulse electro. Not by three of us, for those who aren't, won't be looking at the screen, that's the WellWaveNOW people. That's Dr. Bob, Tim, and Breck. Very much.
I'm a firm believer in pulse electromagnetic
Yeah,
field.
so we're very, very into that.
Yeah.
And that philosophy you went there is, well, there's one out on the market now that says it covers the full spectrum and can address a lot of things to stimulate. But that's also very much in the Rife, what's used to be called the Rife world, the Rife machine.
Right.
I know the frequency of arthritis, and I can dial into that frequency, and I can knock it out. My question will always in that, and at that realm, and you answered it for that particular item what we talked about. My question then was always, well, how do you know that tuberculosis operates at this frequency, and where is your evidence that you've shown that tuberculosis operates at this frequency, and that this will knock it out if you dial into it? Yeah.
So that's a problem.
Mm-hmm.
I don't know specifically how it works.
Mm-hmm.
Okay. So I reserve it for very specific circumstances. So, like, for example, and to your point, would that be how I approach the problem you suggested?
Mm-hmm.
It might be part of the approach, right? And it depends on the symptomatology. If you are in an urgent circumstance, then no, I am not going to use that therapy solely, right? If you are in a non-urgent circumstance, and I think that it's more of a, let's call it colonization problem than infection, then yes, I might very well do that, because one treatment is usually not fully effective. I'd have to repeat the therapy, but same with an antibiotic. You don't take one dose and expect you're done, right? So I might engage in that. And I have with certain people, there are basically processes that we want to reestablish, shall we say.
Yeah.
But there are definite circumstances where I know very clearly, and to be fair, I use the bioresonance more as a triage diagnostic tool than anything else. So one of the areas that I see a lot, so we'll get into an area of controversy, I suppose, but newsflash, COVID and COVID vaccines were bad for you. Okay.
There's nothing controversial about that anymore. The data.
Yeah. Well, so basically, COVID, it doesn't matter whether you had COVID or COVID vaccination, they translate to the same kinds of issues. In some people, there is a significant difference of intensity and effect. In other people, not so much. But what I've seen with bioresonance is some very clear connections. And I actually just read a paper today about MISC in children and COVID. And I have basically making you more susceptible to Epstein-Barr virus reactivation. Well, hell, I knew that years ago, right? I mean, basically COVID and COVID vaccines unroof your protection against chronic viral illness. So we see a lot more of that coming back into the picture. Along with that, it messes up some people's electromagnetic field shield. So their sensitivity to EMF changes. Now, this doesn't happen to everybody. Certainly didn't happen to me, but it's happened to a bunch of people to the point where they can't sit on a Zoom call because once they get off, they can't stand up without falling down.
What percentage of people are affected like that? Do you know?
What percentage? Who knows? I mean, the people who come to see me are the people who come to see me.
Okay.
So
you're
there's
talking about your population. That's not a
selection bias. No. So, I mean, I see a lot of EMF disruption. And then the other piece of that, though, is because EMF shielding has been compromised, the resonance of the EMF impact seems to resonate with resident heavy metal exposure or heavy metal persistence. So problems from the heavy metals seems to be more acute in those people who've had EMF problems. So now you've got this three-pronged collection: EMF, chronic viral stuff, and heavy metals, and people get really disrupted. Now, it's a small percentage, but it is there, and to deny the fact that it's there is really distressing.
Yeah, what you described there, it triggered off in my mind, and I love this conversation. The New Yorker's coming out, and Dr. Bruce, I really like him here. It's a good part. But and why that triggered that, up in this area in the Northeast, Lyme disease is very prevalent, and a lot of things you described there with that sort of bacterial, that viral infection, whatever you go on there, they'll have the sensitivity to the EMF, the 7 intensity screens, the sensitivity to the light. So it's kind of
they go together for sure.
Yeah, disrupted.
One of the things too, I mean, so I've done a fair amount of long COVID work, and this is where you see that. Now, there's some interesting distinctions, right, between sort of classic long COVID and what's the story now. What people don't really recognize is post-viral syndromes have been and are still very common. And COVID was a really bad virus, is a bad virus, though not so much anymore. But once you get it, it's a virus of blood vessels. Well, newsflash, there's blood vessels everywhere, right? So depending on your genetics and your exposure and your current state of health, they're going to affect different parts of your body. And then, because of the way it has affected some of that, it has probably shifted enough of the epigenetics such that you may have chronic problems that wouldn't necessarily be characterized as long COVID, but are clearly COVID related.
So let's take that and pull up you're back into your integrated care world here. Right? It's been a fascinating conversation. It's actually taken long. We have to have you back sooner than we thought we'd have you back, because we only got to about 15% of what we're talking today. But as part of let's take what you went through, we want to talk about, Dave, but let's take what you said there, and in your integrative care approach, how have you gotten different outcomes for those people that have presented with those things than they get by going to conventional? And I hesitate on that because I keep looking for a better word than conventional. It's only conventional here in the U.S., but let's just stay with that.
Well, it was almost stated earlier that a specialist, right? It's not going to be a primary care. It's going to be somebody that specializes. So that's where the integrative care comes in, right? And that's what I wanted to get to as well with you, Dr. Feldman, as do you act as a specialist or as a primary care? But back to your question.
That's a second question. We got to get that. For the first one, gets on your other one that you often get on, Breck, was where are the successes? So I think here he can get on the successes and how he's been able to address that COVID or other things in an integrative care fashion and produce different results for people than suffering for a lifetime with it.
Yeah.
So we have a bunch of those. I mean, there's a program of testing for an immunologic panel associated with COVID. I worked with some guys out of Chicago that's really made a difference. Actually, you use an HIV medicine and a statin, of all things, to impact some of that chronic disease stuff and calm it down. But then that doesn't, basically what it does is it gets rid of sort of spike protein effects, but then you still have all the residual post-viral stuff. So that requires an integrative approach, meaning you can't just do the conventional medical tests. One of the things that's really disturbing to me is that it's very clear, for example, in the post-COVID era, you see people with long COVID, and they want to put people in this graded exercise program. So you start light and you work your way up. Well, the problem is, and how people don't get this, I don't know. You do exercise, you feel like crap for days afterward, right? And it doesn't change. Well, why would you keep doing that?
Right. Insanity.
Right. Yeah. So it required, obviously something is missing. And what was missing was resetting the immune system. And, there's a mitochondrial dysfunction piece to this. There's a detoxification failure piece to this. So, I had a lady who she's an intellectual property lawyer, had a great practice, came to see me, was functioning at less than 30%. Okay. She literally had to hire somebody to do her work because she couldn't do it, period. Right. This had been going on for 2.5 years. She'd seen lots of different folks. Some people have gone to the Sinai program and they got nowhere. We hooked her up with this test. We found that she still had spike protein in her monocytes. They were active. They required this therapy. We did that. We did a bunch of other stuff. We ran her genetics. We ran her adrenal function, her organic acids, a whole bunch of stuff. All of this stuff, by the way, is relatively expensive in terms of dollar figures. None of this stuff is cheap. But, if you can't work, if you can't do anything, it doesn't matter, right?
Yeah.
And these aren't even my costs. By 7 months, she was back better than she had been before she got COVID. And she persists. Now, she's had some periods where she's sort of backslid because that's what COVID does, right? So you need to maintain some vigilance and understand that that's in your background and that you're going to be susceptible. So we have to watch that.
All right, then to Breck's question, can you function as the primary? Can you and do you function as the primary care physician for people?
So for some people, I do function as a primary care guy. It depends. If you have an insurance program that requires prior auths and things like that, you're better off keeping your primary care doctor and using me for whatever you may want. I mean, we're looking at optimizing care, optimizing health. The primary care guy doesn't necessarily do that per se, right? He's going to make sure you don't get sick. And that's fine. And if you have an upper respiratory thing and you want to go see the doctor, you probably don't need to go see that doctor. But if you're going to need referral to specialists and other things like that, it's going to require a prior authorization. There's a whole bunch of insurance related stuff. So from that circumstance, those people probably are better off maintaining a primary care relationship. You don't have to go there more than once or twice a year, but
you don't even want them to deal with you on that basis, right? You don't want that.
I mean, I do. I mean, I will. It depends on who you are. A lot of people, I would like to be their first call, to be honest. Because, you end up, I can't tell you how many people I know or I've had go to urgent care and then I have to reverse all of that stuff, the following week.
Yeah.
Terrible. It's terrible stuff.
So do you take insurance, Dr. Feldman?
I don't. Mostly, I don't take insurance. There are a few very limited exceptions.
Okay.
How about for some of the testing you do? If you do
most all of the testing I do is not covered by insurance. They don't recognize it as real tests, right?
What are some examples?
Having said that, sorry.
What are some examples of the tests that you do that are not covered, not recognized?
Well, so the adrenal tests, the organic acid tests, these are metabolic profiles that, what people don't probably understand is that in the insurance-based world, you have to have a diagnosis in order to have things paid for. Yeah. You can't have I think you might have this, let's check. No. That doesn't work. That won't be covered. So your doctor has to essentially lie, which could be considered insurance fraud by some, if you say you have diabetes, but in fact, you're just checking to see if you have diabetes, right?
We're going to have him back. No question,
yeah.
Dr.
And so, and why I think, when it's feasible and possible, or I might have a discussion on the principles, and I'll tell you what I mean by that. It's like, I would want an integrative person as my primary. And the person I sought out demonstrates some of the characteristics of that. Why? Because what we're talking about, the integrative approach is, and you say, like we're talking about the Ayurvedic, that's meant to maximize wellness. Integrative approach is meant to maximize wellness. So without someone like that, I've got to be and I do, and I think we all do, I've got to be my own integrator. So I choose, do I do yoga? Do I do Tai Chi? Do I use PEMF? Do I use some other form of magnetic resonance? Do I use red light? So I look, we didn't get into the part of the thing that I also like about Dr. Bruce, where he will, he alluded to it, where you get into even to the spiritual part of it and things if necessary. So I work my own spiritual part of it. So
I can tell you, nobody does what I do.
Right.
I know that nobody does what I do.
Right. But
People
and you're probably
people
correct
approach
on that.
people approach what I
Sure,
do,
people approach it,
right?
and
And
I
they
think
do, and there are plenty of people who have open minds and are willing to work with other practitioners to provide an integrative service, right? But I know nobody does what I do.
right. And
It
so,
really
that's what we want to. That's what we want to do. We want to get people with understanding. I was leading people down this path, and I don't want to lead people down this path. We want to educate people so if they choose to take this path, they know they can take it. They ought to find people. I think you talking about this with us and with others can help them educate that. Might even educate some providers to move down that path as well. And if people can find, in my opinion, if they can find people as close to what Dr. Bruce does as possible, they're better off. Or they've got to start doing more of it for themselves and get educated to do that. Now, can you help people out? You're a New York-based person, and
right. So I have
but let me. Now this one I might offend you on. When you said earlier on that question, almost offending you. I'm originally from Central Nebraska. When I told Central Nebraskans they were like New Yorkers, they felt they got offended. When I often told New Yorkers they were like Central Nebraska, they said, "I'm not like those hicks out there." But there's a lot. The only difference in terms of some of the bluntness, the honesty, and the approach, and the whole care, it's in the emotion. New Yorkers are more
delivery
and delivery.
Yeah.
But can you help? Can you help those people that are like you out there in Nebraska somehow, being located in New York, Dr. Bruce?
So I'm licensed in the state of New York
Right.
to provide medical care, right? So
Right.
my medical malpractice only covers me for services in New York. Now, during COVID, all the telemedicine stuff, it was wide open. You could do anything. Can't do that anymore. So what I've gone to, and this is where you should maintain your primary care doctor piece,
Mhm.
right? I can provide you sort of medical grade advice that is not medical care. So I'm not going to prescribe anything, but I can make suggestions and I can give you a series of possibilities and sort of grading them for you so that you have a path that you can follow and then I can follow along with you. Okay. So it's subtly different, I think, but it doesn't count under the medical practice anymore. It's more of a elevated health coach, which if you're not writing for prescriptions, it's,
easy to justify, right?
And
not that much different. So.
For our listeners that don't see your email on the screen, it's drbruce@feld, FELD, med.com. That's
love that name. Love that name. FeldMed. I love that. It's really good.
Thanks.
Well,
New discipline.
It's been a huge enlightenment, and we absolutely need to have you back because we literally didn't even get through half of the things that we intended to get through with you today, Dr. Feldman. So it was great to have you on and to better understand your, patient first approach. I think that's key right here is that it's, what's the best interest of the patient, not what's in your best interest or some health system that's saying what can and cannot be done. So thank you for what you do, and it was very enlightening and it's timely too. It's you're getting real world results with integrative care, and we thank you for the work you're doing. So until next time, stay curious, stay empowered, and remember, wellness, it's in you.